Lovely. Thank you very much, Peter, Joe, and to Hamish and everybody else for inviting me. That's alarming. That's moved without me touching anything. So I'm going to talk about HCC risk scores. I'm going to talk a bit about what the purpose of surveillance is, because I don't think you can have a risk score if you don't know what it is that you're after. And I think the talk that Peter's just given, acknowledging that there is some uncertainty in the evidence around how effective surveillance is, which patients should be included, which tests should be done, in whom and when, highlights that this really is a very, very challenging topic. So this is a statement that could come from any of the guidelines, comes from an AASLD guideline. The objective of HCC surveillance must be to decrease mortality from the disease, meaning HCC. Fewer people should die from HCC, or if this isn't possible, surveillance should at a minimum provide a meaningful improvement in survival duration. So that's a lot of words, isn't it? And I think to try and understand that, here's a sort of annotated patient journey. So this is a patient who has a diagnosis of cirrhosis. They don't enter surveillance for whatever reason. They develop an HCC which is undiagnosed, then develop symptoms and die soon afterwards. And this, unfortunately, is a scenario that we're all too frequently faced with in the clinic. The purpose of HCC surveillance is to try and detect that cancer soon after it arises so that treatment can be given. And that's what happens here. So same patient has surveillance, cancer's detected at 1.5 centimetres. This is a success of surveillance. They have ablation, they have a complete response, but because of the nature of HCC and cirrhosis, they develop multifocal recurrence and die a bit later on. So their lifetime has been extended, but they still die of HCC. So this is successful surveillance. This is the same patient, but in a parallel universe, in the multiverse. So here they have ablation, and then sometime later, 12 months perhaps, they decompensate acutely and die from liver failure. So as it's defined in the guidelines, that's a success of surveillance. They haven't died of HCC, but they have still died of their liver disease, in this case dying of liver failure. Their lifespan's been unchanged. And so this is an illustration of overdiagnosis. And this concept of overdiagnosis is really important. This is the reason why patients who, healthy people who are invited to screening for breast cancer, that stops at the age of 70. Because once you're older than 70, the risk of comorbid conditions dying from another reason rises so quickly that that risk of overdiagnosis, dying of something else before you would have died of breast cancer, becomes important. And ultimately, if you're a patient or an individual, if you've died, it doesn't matter why you've died. And if we diagnose HCC early for a patient only to die of liver failure some months or perhaps a year later, that's not a success of surveillance. So let's think about these risk prediction models. So, existing models. So risk prediction in cirrhosis is difficult. And if you think about a patient who's got compensated cirrhosis, they're at risk of 3 main events. One is death from a non-liver cause, and in people who've got MASLD particularly, that's very frequent. They're at risk of decompensation, and they're also at risk of developing HCC. And I think it's really important to remember that of those 3, HCC is the least frequent event, and it's the least frequent event by some distance. So predicting HCC in the context of these competing risks is a real challenge. So there are lots and lots and lots of risk prediction models because it's very easy to make them. So these are some examples for patients who have non-viral liver diseases, alcohol and MASLD particularly. And these have been summarised very nicely by my research fellow, Laura, who's sitting at the back, who's going to wave now. Yeah, just to acknowledge that this has been an enormous piece of work trying to put this together. And you can see on the left-hand side of the slide the types of information that's often included in these risk models. Age, sex, diabetes, blood results, fibrosis stage. Those parameters are put into a model and an estimate of risk is then made. Competing risks, thinking about decompensation, death from other causes, rarely considered. And actually, for a patient where those events are much more common, really need to think about those. And when you look critically at all of those studies that have been published, 10 or 12, they're all reported poorly, they're all at high risk of bias, And actually, those patients who've got alcohol-related liver disease and MASLD, where larger cohorts have been collected, they're grossly underrepresented. And the reality today is it's those patients who we want to assess risk for and put into surveillance. In terms of hepatitis B, there's a similar number of models here. You can see there are 12, and you can see again the types of characteristics that are included: age, sex, presence of cirrhosis, other lifestyle factors, alcohol, and then hepatitis B parameters. But the reality is that actually, regardless of disease etiology, none of these models are sufficiently well developed, externally validated, and particularly calibrated so that a prediction that's made does represent a true risk, that they can be used in clinical practice. So the idea of HCC risk scores is interesting, and I think it's important, but we're not at a position where we've got one that we could pull off the shelf and use today. So how might we improve risk prediction? So over the course of the last 10 years, the hepatologists in the audience will have spent a lot of time going to meetings about MASLD and biomarkers in MASLD, and there are very strict rules about how you develop a biomarker, which patients you should use it in, how it should be used, and what it's predicting. And actually, from a predictive model perspective, if we adopted some of those ideas, then we'd have a much better idea what the model was for. We need to be able to specify what the target condition is. Is it prediction of HCC? Is it prediction of HCC before decompensation, which I would argue is a much more patient-relevant and important outcome? If you've already decompensated and I can predict that you're going to get HCC, that's not a very useful thing unless I'm going to have you on the transplant waiting list. And then we need to think about the context of use. So which patients, where, and when. So what I'm going to try and do now is to put a couple of these things together, because it's important that we try and understand in sum how these might work. So let's think about competing risks and the target condition. So what Laura did again here was to generate a single predictive model for HCC in a cohort of about 1,500 patients who've got compensated advanced chronic liver disease. And you can see on the left-hand plot for HCC that predicts, stratifies people into high risk, intermediate risk, and low risk. But actually, if you use the same risk categories and look to see how frequently they decompensate, you can see that the rates of decompensation are much greater. So if you've got a patient who's at high risk of developing HCC, these are the patients we want to put in surveillance. High risk cancer, we'll find the cancer and treat it. But if you look at this by, whatever it is, 10 years afterwards, 40% of them, perhaps more, will have decompensated. And their life expectancy is going to be governed by decompensation, not by the presence of liver cancer. So using very high-risk patients to identify the right people to go into surveillance may not actually be the right approach. And using more costly tests more frequently in a high-risk population certainly needs to be considered. So what happens if you compare these models that include competing risks with the standard type of models that are built? And here you can see that actually, by considering competing risks, that lowers the estimation of risk. And we know that from other studies. And that will significantly reduce the proportion of people who might need to enter surveillance because their risk isn't great enough. And if these models were the same, then that would be a perfect line that went from 0, 0 to 1, 1, but it isn't. It's reduced in those patients where you consider those competing risks. Where those dotted lines should be, which patients should go into surveillance, which patients shouldn't, Hamish is going to tell us the answer to in a moment. And then lastly, to think about etiology. So because most of these models come from academic centres, they are built on the individual investigator's favourite disease, because that's what academics do. You know, we have our favourite disease, we study it, and then we make a model. But actually in my clinic, where I see unselected patients with cirrhosis, that's not a helpful thing. You know, I want a model really that's going to encapsulate risk for all patients, whether that's a patient who's got MASLD, a patient who's got alcohol-related liver disease, a patient who's had prior hepatitis C. There are lots of ways to skin that cat. You know, you could have multiple different models for different diseases, or you could have a single unifying model. It doesn't matter, but you need to be able to do both. So I'm going to finish there. This is a complicated topic delivered in 10 minutes and 30 seconds. Risk prediction and compensated cirrhosis is a challenge, whether you're predicting the risk of decompensation, predicting the risk of cancer. Any benefits of surveillance, whatever those are, we don't know because we don't have a reliable randomized controlled trial, but any benefits from surveillance are at risk from overdiagnosis. That's cancers detected where patients would die from other causes. Predictors of HCC and decompensation, at least in the models that have been built to date, are similar, and that means that if you predict a patient being at high risk of HCC, it's likely they're also at high risk of decompensation. And the models that we have now are not ready for implementation. There are still many unknowns. And if you try and put this into a biomarker statement, we don't know what the risk prediction score is, but that might be used as a predictive model when evaluating patients with compensated cirrhosis from diseases X, Y, Z. We don't know what those are either. For the risk of developing, now I know the answer to this last question because I've made up my mind, but prediction of HCC before decompensation. But there isn't agreement amongst the community that that is the appropriate target condition. So in terms of making predictive models for the identification of people at the greatest risk of HCC to enter surveillance, then we're still a long way away from where we need to be. Thank you.